this out of the way. So if I spontaneously combust and you take nothing else from what I say about the new opportunities in Medi-Cal, one thing that has happened is we have removed diagnosis as a prerequisite for care. So just hold that one for a second. For those of you who maybe have referred a kid in child welfare to mental health and been told they don't meet medical necessity, that should not happen anymore. We are now accepting and understanding the power of adversity in shaping the lives of children and families. So we have to expand eligibility criteria, and we've done that. Now, it hasn't shown up in our systems yet, but the rules have changed. And then obviously we have to increase transparency and accountability. So I just wanted to give you a little bit of a framework about what you're going to hear as we dive into the details, is that as we've tried to reimagine the youth mental health system in California, we've used this framework to approach it, and it's included a bunch of money that we'll dive into. Brian.
Thanks, Alex. So we're going to start with a little bit of a history lesson, and then we're going to go to math. And so I really appreciate the fact that there's 70 people that want to have, it's both math and history. Thank you. You guys are awesome. I'm going to spend a little time on the next two slides around the history, because I think it's helpful to figure out where we are and what the context is, how we got here, but also how we can get out of it, and why Medicaid is so important from a child welfare prevention lens. And as you know, not to give up the plot right away, but in a lot of ways, it's the best thing we got. So child welfare through the decades, so early 1900s. If you go before the early 1900s, we're talking indentured labor. We're talking about kids who were put into indentured labor after their parents were not able to take care of them. 1900s, you get the mother pensions. What are those? Well, in a lot of ways, the first funding for child welfare in the United States was prevention funding. So 1910, 1920, the mother's pension laws that came out of organized groups of women who were concerned that most children ended up in orphanages because they were relinquished by single moms. So not because of actual neglect, not because of abuse, but because they were relinquished by single moms who couldn't afford to both work and care for their children, couldn't do both. And so in a way, the earliest funding was prevention to stop that from happening. Sound familiar? Sound like what we're talking about in the modern landscape in some way? By 1920, 40 states had these pensions, but they were sadly inadequate. They aided a tiny percentage of those in need. They discriminated against immigrants and non-whites. They never provided enough funding to really help. And so to put that in context, so about 93,000 those families received help out of 1.5 million who really needed it. This is a theme in the United States. Then we have the Social Security Act 1935, later became known as Title IV-B. That's the first federal grants. It led to the establishment of the first child welfare agencies in some states. A lot of other states, though, didn't have child welfare agencies at all. Then you had AFDC-FC in 1961, that's Aid for Dependent Children Foster Care. That was partially to help states comply with the Fleming Rule. What's the Fleming Rule? Well, Fleming Rule was a response to the Louisiana incident. What's the Louisiana incident? Well, I mention this because this tells us where our country was. So in the Louisiana incident, Louisiana expelled 23,000 children from its welfare rolls. Why? Because they had determined they had been born outside of marriage. And so from a morals perspective, they didn't want money to go to them, and so they kicked them off the welfare rolls. So AFDC-FC in 1961 created federal funding in order to help states not do that and made them not be able to do that. But not until 1967 that AFDC-FC became mandatory. So it was 1967 when we had mandatory child welfare agencies in all the states, and they had to take the AFDC-FC funding in order to create it. And then in 1974, we got CAPTA, which required states to develop child abuse reporting and investigation systems. That's where our child welfare systems come from. This, in turn, led to a super rapid growth in foster care rates. So you develop the system, develop the funding, and then all of a sudden there's a lot more kids in funding. Remember, we started this with funding for prevention, and then ever since it's been funding for kids in care. Not on this slide, but incredibly important to help slow that growth in foster care rates and preserve families was ICWA, the Indian Child Welfare Act, which was passed in 1978, designed to keep children with families and to prevent them from going into care altogether. 1980, we get the Adoption Assistance and Child Welfare Act. That's the first time the federal role was really expanded into the administration and oversight of the child welfare system. It established rules governing like all the things that we think about when we think about child welfare processes. So case management, permanency planning, placement reviews, state plans on how child welfare services will be delivered, reasonable efforts requirement, and established the adoption assistance program. So funding for children to be able to leave care in order to go into adoption. Family preservation and family supports, 1993. That was funding to prevent child abuse and though to help families whose children were at risk. So again, some funding for prevention, reauthorized and renamed under ASFA as promoting safe and stable families in 1997, added time-limited family reunification, and then redone in 2001 again, but the funding is still really small, which again is a theme. 1994, you had child welfare waivers, which the idea was to provide flexible funding for innovation, kind of out on whether or not it really did that. And really the real impact was later in 2010 when ASFA expanded them. Adoption and Safe Families Act from 1997 expanded those waiver programs, established child safety and expedited permanency procedures and financial penalties around performance standards. And then you got Families First in 2018. So some of you may be thinking, oh, so we finally got prevention funding in 2018, but we're going to talk a little bit about that because remember how I talked about women's pensions and how it was inadequate funding? Well, Families First so far, and I'll shoot again, giving a spoiler alert, has only provided assistance for 6,500 children nationally. So we'll talk a little bit about why that's true in just a second. And then we get to today, which is upstream prevention. Alex, can you go back one slide? Underlying all of that legislative stuff is lots and lots of court cases. Also, so this is why we kind of have a Frankenstein of foster care benefits programs and funding is on the 40 side and foster care side. Almost none of this funding has to do with prevention. As a matter of fact, a lot of these court cases had to do with not adequately funding kids who were in care, much less doing prevention. For example, Yoakum was whether or not states really had to fund relatives who were taking care of children in the foster care system. Yoakum said you had to if you were using federal dollars. Lipscomb said you didn't have to if you were using state dollars. And as you might know, in California, we didn't provide foster care benefits. 2 kids who were placed with grandmas, 2 relatives, if they were not federally eligible, all the way until we fixed that through the Approved Relative Funding Option Program very recently in 2014. And then next slide. So that's kind of how we got here. It's super fragmented. It's a super Frankenstein monster of child welfare funding benefits. And then also, if you just look at this, so where is the need? So 7.4 million children referrals involved in referrals alleging maltreatment. Let's say the need is there. So where does the funding streams actually get to you? The vast, vast majority of foster care specific funding streams, you have to go all the way down to the 273,500 children who are entered into foster care before you can legitimately leverage funding, federal funding that makes an impact. Next slide. And then if you look at the, where is Medicaid, for example, for the missing funder? So this is the funding streams that we're using child welfare. These are national numbers. We have slightly updated. I apologize. This is 2012. We have numbers from 2019. The percentages are the same. The overall spending has increased slightly. So Title 4E of the Social Security Act, that's the main foster care benefit. When we say foster care benefits, federal foster care benefits, we usually mean 4E. It's about 50% of the spending nationally, federally. TANF is about 22%. In California, TANF is actually only about 11% because California uses TANF predominantly to assist children that are living in poverty instead of children that are in foster care. Social services block grants about 12%. Look at that Medicaid number though. It's only 8%, which makes really no sense and will make even less sense when Alex describes what the eligibility factors are for children to receive assistance through Medicaid funding. Next slide. So if we're looking at Medicaid and child welfare impact areas, where can we do the impact? Where can the actual funding happen with Medicaid? There's really 3 main categories. Upstream prevention, and that's very important. If you think about Medicaid, somewhere between 80% and 90% of all children, when they come into the foster care system, are Medicaid eligible. And so that upstream prevention, you can do that through Medicaid funding much sooner then you can through anything related to the foster care funding, including Families First. Also intensive evidence-based services, both for children who are at risk of coming into care, don't need care at all, and kids who come into care. And then using Medicaid funding for those tailored services for children who actually are admitted into formal foster care to proactively address the trauma, both the trauma that led them to be involved in the foster care system, but also the trauma that is caused by the foster care system. Next slide, Alex, turn it over to you.
Many of the same factors that are driving child maltreatment are the focus of the evolving Medi-Cal reform initiative in California. So basically, there is a huge overlap between the intent and purposes of the reforms that the state is leading and the intent and purposes of the reforms the child welfare system is leading. And that's a little bit of what we're here to talk about today, as to how to navigate the child welfare focused strategies of FFPSA, frankly, the legacy of continuum of care reform and all of that work, and work under CalAIM and the broad general acceptance that you don't treat away poverty and racism, and that these essential concrete supports to help families address their needs, but also connect and thrive, are essential to transforming both of these systems. So what we're suggesting is maybe it's like peanut butter and chocolate that just haven't met yet, but if they couldn't meet, maybe we could achieve a common purpose. Sorry, y'all, I'm frozen here. There we go.
I'm good.
So Medicaid and prevention, I mean, I think to Brian's point, couldn't we all reasonably agree if every low-income family got what they needed, a lot fewer kids would come into care? And that's basically the essential premise of today's presentation, is that the vast majority of young people and their families would benefit from expanded access to the social and emotional supports that are the focus of the reform landscape in Medicaid. So why has state Medicaid innovation been so slow? And as I'll show you in a second, I think it would be fair to say that we suck. Like, that's my clinical prognosis for California's Medicaid program. And why has it been so difficult? Well, we have a medical model. And I think we have to confront the reality that the medical model is only appropriate for a small number of young people. I have literally billed hundreds of millions of dollars of mental health services to Medicaid, and very, very few of the children and families I served were actually mentally ill. I would say somewhere between 15 and 20%. We also have this traditional and functional barrier between the human service side, the concrete support side, including child welfare, and our healthcare system. And we have to acknowledge that all systems at the local level are constrained by a lack of non-federal dollars. Remember, the federal match is almost always guaranteed, and we're going to dive into this. What's not available is those scarce non-federal dollars. So as we design upstream prevention programs, what can we do in the Medicaid space? Well, we can do screening tools, as we are doing with our ACEs screen and our ASQ and developmental screens. We can offer fiscal incentives for social care. We'll dive into that a little bit. We can do closed loop referral systems. This is a fancy name for things like Unite Us or Find Help or One Degree. We can come up with different and new providers who are culturally congruent and concordant. We can eliminate diagnosis, and we can expand access in non-traditional setting like schools and community-based settings like FRCs. So this is kind of the takeaway, y'all. Like, these are the essential elements of the reform landscape in Medicaid that we want you to track. The new screening tools, the new reimbursement mechanisms like enhanced care management and community supports, the new service directory and closed loop referrals, the new provider type opportunities, and the fact that we have eliminated diagnosis as a prerequisite for care. These are these same things that I just named, which is, if you're going to track, if you try to see the forest through the trees of CalAIM and the reform landscape in Medicaid, know that we've removed diagnosis. We are reforming how we claim. So your partners in county mental health are going through fundamental transformation in how they get their matching funds. Schools and pediatric primary care are becoming brand new service settings for mental health. Dramatically expanded access to mental health when you bring your baby to the doctor and when you go to school. There are tons of new eligible providers. Managed care plans are the center of the universe. So traditionally, your partnership has been with your county mental health department. And I'm going to need to invite you to open your mind and heart to think about the Medi-Cal managed care plans as increasingly important partners as you build services and supports. And there's a huge focus on care coordination. So what are the takeaways? Things are actually changing. We have the nation's largest Medicaid program, and it is fundamentally being reformed. If you're in child welfare, you need to know that Medi-Cal, California's version of Medicaid, is not just one thing, it's many things. And you actually need to know at least 3, if not 4, of these major payment systems in order to effectively leverage services and supports for the children and families you serve. And by the way, to negotiate the payer of last resort issue. So one thing to do is track the new benefits, particularly the family therapy benefit and the dyadic benefit, and enhanced care management and community supports. We'll go into those a little bit more directly. And then mine the new provider types. We are not going to heal in 50-minute sessions with psychotherapists. We're going to heal in relationship to each other and with each other. And these new provider types are one of the greatest opportunities we have to democratize the delivery of social and emotional supports. So think doulas. Doulas get paid $1,200 a birth. They went live in January. Almost all low-income families now should have the positive experience of working with someone who looks like them during their pregnancy journey. And then finally, and this is our lesson on the math side, mine for this thing called a certified public expenditure. The plumbing is clogged because of a lack of access to non-federal dollars. So to distill the sustainability issues, know that the health plans are increasingly important. Behavioral health is changing. Medi-Cal will pay for things it didn't pay for before, and will pay for people to do things who it didn't pay for before. And the crisis is real. This data is from before the pandemic. So what I would invite you to hold is, don't believe the hype. The pandemic didn't create the youth mental health crisis. It poured a bunch of gasoline on the fire. In the decade before the crisis, before the pandemic, we saw a doubling of inpatient admissions for self-injury, a 50% increase in pediatric bed days. Young people were telling us through the California Healthy Kids Survey. And we ranked 44th in the nation in screening, but actually 48th in access to care for kids. So if you're in the child welfare and foster care system and think, wow, our children's mental health system really sucks, you're right. But it's changing fast. So let us not imprison each other in dysfunction, and join us in reimagining the system to improve it. COVID did these things, and remember, these slides are for you. We hope you use them. These are the CDC data on the impact of COVID. But when you look at it and bundle it all together, there are 5 level 1 pediatric trauma centers in California. One of them is Rady Children's in San Diego, and it saw a 1,700% increase in emergency department utilization. If you've ever been around or worked in an emergency department for kids, they tend to be pretty small, like 4 to 6 rooms. So these type of increases are almost unimaginable in sort of the general acute care hospital setting. So our payment and delivery system simply must change. I mentioned that that schools are essential because 75% of mental illness manifests when young people use the system the least. We have provider shortages, so even if you wanted to give everybody a therapist, you couldn't. I say thank God. Like, I see the provider shortage as much as an opportunity to transform our delivery system as it is a barrier to care. And diagnosis-driven models are only appropriate for some children. The vast majority of young people are living in a culture that told them they're not worth anything. And that's the challenges that our mental health system must address. How did we get here? We don't have a common framework. Our public systems are fragmented. You all know this, you live in it. And we haven't even fully clarified if mental health is an essential benefit in a health plan or a public health utility. And finally, and most importantly, our definition of medical necessity, meaning what qualifies you for care, is outdated. So this crisis is real, but there are actually some really hopeful things. There is political will, meaning we have state and federal leadership who have made unprecedented investments. Californians say this is among the most important things to them. And we have an emerging consciousness and understanding in the Medicaid space that adversity and structural racism are driving this crisis, and traditional medical model intervention must be changed. And we have a reform landscape that is fundamentally transformed. There's $10 billion. And I'll go through the Youth Behavioral Health Initiative in a second. But in order to fundamentally, remember that slide I did where I said both Medi-Cal is trying to address the social determinants of health and child welfare is trying to get upstream? The nexus of the two is the opportunity. But to take advantage of this nexus, we have to understand the centricity of the health plans. The county you live in has increasing investment in the Medi-Cal managed care plans. And we must change how we finance and deliver, how we pay for and do, and focused on team-based models. The days of a therapist working alone, providing 50-minute therapy sessions needs to be over. A therapist should work in partnership with health workers, with wellness coaches in schools, with doulas or peer support specialists, and together they should manage a panel of young people. Those healthcare system for people and by people are those new provider types. And as I mentioned, please help join me in reimagining mental health as a support for healthy development, not a response to pathology. We have constructed a toxic culture for children, and we must teach them how to navigate and thrive it. So Medicaid covers a third of California. The total spend on behavioral health is only $12 billion. And it covers a third of all Californians. But for kids and parents and mothers in particular, it's different. Medi-Cal actually covers half of all births. And when you look at who kids are covered, actually almost 60% of kids are covered by Medi-Cal. So again, this idea that young people who, if they had gotten everything they needed, they and their parents, couldn't we reasonably project that fewer of them would need services from the child welfare system? And kids get mental health services from two different systems, from the specialty system, the county mental health plans, and the non-specialty system, meaning the managed care plans. And the managed care plans only had that benefit beginning in 2015. But just in 8 short years, the systems have become almost equivalent by number of kids served, though the service is fundamentally different. The managed care plans spend about $1,200 per kid. The mental health plans, the counties spend about $8,000 per kid. But we still rank in the bottom third of spending nationally. Children are 42% of all enrollees in Medi-Cal, but only 14% of expenditures. We rank 44th, actually 48th now. And it is no news to those of you working in child welfare that California's Medicaid program is deeply troubled. That's the whole reason we did CalAIM, and we're doing the Children and Youth Behavioral Health Initiative. So while Medi-Cal eligibility has increased, it's covering almost 60% of all children now. It covers kids up to 266% of federal poverty, regardless of immigration status. So in 2015, we rolled in healthy families to Medi-Cal, making it one program, and we added undocumented children through SB 75. And for parents, any parent under the age of 25 is already eligible for Medi-Cal. The state is going to bring in the 26 to 50s this summer. The 50s are already in. So soon and shortly, all low-income families, regardless of immigration status, will be eligible for Medi-Cal. But we continue to struggle to get access to care. Less than 6% of all children receive anything at all, and less than 3% are in ongoing care. And if you don't just aggregate this data by race, you're missing the point. 81% of children on Medi-Cal are children of color. The suicide rate is 2 times that for Black boys than it is for white boys. And we all know the nexus of the juvenile justice system and the failed children's mental health system. So making our systems healing centered isn't just about shifting how we pay or the type of methodology we use to claim. It has to be about addressing and acknowledging the fundamental role of structural racism and poverty on the social and emotional health of children and families. So in 4 minutes or less, I'm going to teach you how Medi-Cal works. For children in Medi-Cal, the federal match is guaranteed. And all of Medi-Cal works the same way. It has 2 components. It has a non-federal share and it has a federal share. Together, they make up a Medicaid expenditure. For those of you who do 4E, this should sound very familiar, right? Same thing. That non-federal share has a formal name called a certified public expenditure. And if you remember from a previous slide, I want to turn everybody into hustlers. The purpose of today's presentation is to help you identify CPEs in your county that could be eligible for federal matching funds, both to fund your prevention plans, but also to expand access to Medi-Cal. The federal match is called federal financial participation. That should be familiar to you. And, oh, sorry, this is Brian. Go ahead, Brian.
Well, I just want to compare the Medicaid, which is in a lot of ways the last great benefit, to actual foster care funding. So with foster care funding, can you click it again? I need the left side of that slide. Your slides are so fancy. The federal match for 4E foster care funding, that's not guaranteed because the way that foster care funding works, it's everywhere in the country. This is not just California. There's two programs. There's the federal side and the state side. Reason why is because, can you hit it again? Actually, you just hit it a couple more times where you get the whole slide there. I can't, there you go. Because it's 4E eligibility. So whether or not a child in foster care is eligible for the federal match is dependent upon whether or not, it's really complicated, doesn't make any sense. It's based on the home of removal where the child doesn't even live anymore. And the home of removal has to meet AFDC standards, which is the welfare program that was in effect in 1996. So it has to be poorer than poor. The family could be eligible for TANF, still wouldn't be found eligible under the AFDC program because it was phased out in 1996. And the child has to have lived in the home of removal the month the petition is filed or anytime 6 months previous. All of that means that it doesn't make sense. And only about half the kids in California that are in foster care are federally eligible. The other half is state dollars or realignment dollars in order to pay for all of them. So you have half where you have the federal share plus the CPE or plus the non-federal share, and half which is just straight state dollars. Importantly, for those kids that are state dollars, you can use that to leverage other federal dollars because it's state. FFSPA on the other side, that's the 4E prevention through families first. That federal match is guaranteed because they eliminated the look back. They eliminated all this stuff. So you don't have to worry about that. If the child is eligible for families first, then they do get a federal match, but that is proven to be very difficult to implement nationally. And we'll talk more about that in just a little bit.
Thanks. And I'm just seeing some of the chat now. And we will dive a little bit into some of the new Z codes in family therapy and the dyadic benefit in a second. So I saw that one question. Sorry, y'all, I'm hung up again. So let's talk about how that federal matching for an EPSDT, where it actually is in the Medicaid side, where it is guaranteed. Let's talk about how that federal dollar flows through the state and shows up in the lives of children and families. So do you remember how it was so simple, right? Like there's a CPE, there's a federal match. Seems pretty straightforward, right? Well, this is the architecture of our failure. That federal match flows through the state and shows up in the lives of children, first and foremost, through the managed care plans. And remember, regardless of what you think of it, whether you believe in county-run systems or managed care systems, the reality is that most of the reforms of CalAIM and the Medi-Cal landscape are coming through the health plans. So if you ignore the managed care plans, you are ignoring the single largest opportunity to change our dysfunctional Medi-Cal program. And so the vast majority of our opportunities rest here. But there's also the county mental health departments. There's also the school districts who can bill directly. There's also community health centers who get an enhanced rate for services they provide to Medi-Cal beneficiaries. There's also public health departments that can claim case management and administrative activities. There's public hospitals who have their own claiming mechanism. And there's the regional center, which is a 1915I and 1915H waiver program itself. These are the many faces of Medi-Cal in a local jurisdiction. And those of us who've worked in and lived in these bubbles our entire careers know you spend a lot of time pointing your finger at the other bubble saying, no, you pay. One way to look at CalAIM and the reform landscape is that the state envisions the managed care plans as the air traffic controller or the healer of this fragmented safety net. And if that makes you scared and say, geez, how are they going to do this? They don't know nothing about my work in child welfare. That's probably a good fear, but we got to teach them. Remember, one of the populations of focus of enhanced care management is our young people involved in our system. So teaching health plans how to support and work with both mental health plans and child welfare agencies is one of the great opportunities before us. And again, why is it so important? Well, all of our child serving systems work the same way. There's a federal statute tied to a state action, but almost all of them are administered at the county level. This is true of child welfare. It's true of juvenile justice. It's true of early childhood to the degree we have an early childhood system, first fives. It's true of LEAs and county offices of ed. It's true of the regional center. But the common denominator of almost all of them is Medi-Cal. We can reform these systems if we reimagine Medi-Cal as a healing-centered tool for social justice. If we remove it from the medical model that pathologizes low-income communities and infuse it with the principles of social justice and community action, it can become the leverage to transform our child-serving safety net. We saw examples of this. The county I worked in was a 4E waiver county. We had 6,000 children out of home placement. We ended up with 1,500. The pendulum may have swung too far. In juvenile justice, we had 450 young people in our juvenile hall. Today, there's between 35 and 50. Most of these strategies have had some tie to an enhancement of community-based mental health services as a mechanism to support the transformation of these child-serving systems. So do we have the skill and will to build these team-based models of care that integrate payers? The future of this nexus of child welfare and Medi-Cal is going to require managed care plans, mental health plans, and the provider class, FQHCs and hospitals, to work together in new ways. And the opportunities are going to be funded by CalAIM and the Children and Youth Behavioral Health Initiative. So to try to get your brain around this landscape, I've tried to bucket it out for you in three big places. The first is the Children and Youth Behavioral Health Initiative. And I've highlighted three essential elements of it. We'll drop a link in the chat as soon as I finish presenting that distills the initiative. But first is there will be new wellness coaches in schools, up to 5,000 of them beginning in 2025. The new dyadic benefit allows us to treat caregivers when they bring their babies to the doctor. The paper that created the benefit is called Babies Don't Go to the Doctors by Themselves. You don't even need to read it. You now got it. And the universal fee schedule is our attempt to create schools as automatically in-network for payers, both commercial and non-commercial, meaning schools are the mental health clinic of the future. Kids 0 to 5 and their caregivers will get expanded access to care in pediatric primary care, and kids 8 to 18 or 8 to 24 will get access to enhanced mental health supports in their schools and community colleges and institutions of higher education. CalAIM is a ambitious transformation of our Medi-Cal system. It has a number of things to hold on to, but actually the number of actionable things, particularly for the child welfare system, are pretty narrow. First is universal eligibility for system-involved children, meaning the access criteria has fundamentally shifted. Criteria 1 of the new 1915B waiver grants universal access to kids with child welfare system involvement, and enhanced care management has a population of focus specifically targeted to our young people. There are a bunch of other things, including community supports and grant programs to watch, but I think the essential things for child welfare to watch are the new access criteria and the new benefits related to care management through the plans. I would add a little bit, and I will in a second, the new non-specialty mental health benefits, particularly the family therapy benefit and the dyadic benefit. Finally, the state made a bunch of big investments through schools, and the feds did through ESSER, the $4.4 billion Community Schools Partnership Program, the Expanded Learning Opportunities Program. Young people should be able to get expanded access to support and care in their school-based settings through these programs, including mindfulness and the peer-to-peer demonstration project. These are the 10 essential elements of the Youth Behavioral Health Initiative. Again, the ones I would highlight are the dyadic benefit, number 5, the workforce stuff, number 6, and the new role of schools as automatically in-network for all payers. This is called the universal fee schedule. Schools can and must be, meaning healthcare systems must use schools differently. One way to think of what the Youth Behavioral Health Initiative is trying to do is make schools as important to healthcare networks as hospitals, as ambulances, as doctors' offices. So the healthcare system needs schools. Schools aren't a hand out. To Medi-Cal, they're a hand up. And the finances align because schools have access to the type of dollars that are eligible for a federal match. So we have to look at, that's where kids are. Number 1, there's opportunities to braid funding. And number 3, we actually have an agreement on how to do this. It's called the MTSS. And we have an agreement on the mechanism. It's called COST, which is school's name for multidisciplinary teams. I mentioned the provide classes as this important new opportunity. There's 4 fundamental ones to track: the doulas, community health workers, certified peer specialists, and wellness coaches in schools. And we have a piece on how to hold these provider types, meaning how to think about their credentialing, paneling, and reimbursement structure. But let's try to lay out for you what this means. There's a whole series of new peer-to-peer programs in high schools where young people can get a stipend to help each other. There's the Cal HHS demonstration project, but there's a number of these programs being funded by the Student Behavioral Health Incentive Program, as well as the Community Schools Partnership Program. But that really should just be the beginning of a new career pathway for low-income young people to engage in new models of support. They could graduate high school and become peer specialists. They could become community health workers. They could become doulas. They could become wellness coaches at the associate's degree and the bachelor's degree. They could already become rehab specialists and OQP in the mental health plans. And we've added marriage and family therapist interns and associate social workers are now eligible to get reimbursed through FQHCs. This is called SB 966. And then finally, a licensed therapist. So this is a whole new career pathway that we've created for people with lived experience to become essential actors in a response at scale to the youth mental health crisis. And for those of you working in child welfare, I think it's really important to understand that Medi-Cal is dramatically expanding the nature and type of providers that are eligible for reimbursement. So reforming access criteria is really, really important. This term, you know it as medical necessity, and the removal of diagnosis as a prerequisite for care is one of the most fundamental changes that has happened in California's mental health system. And I saw that one question in the chat. The new family therapy benefit is the first and only benefit in any Medicaid system in the nation that qualifies beneficiaries for access to care based on an experience of discrimination, on housing instability, on food insecurity, or any of the other adverse child experiences. So Z65.9 is the qualifying Z code that gets you access to these services and supports. The family therapy fundamentally transforms and reimagines our access and eligibility criteria for mental health services. And the dyadic benefit goes a step further. It creates an opportunity for adults, Z78.1, to get access to social and emotional support with no diagnostic criteria, no DSM qualifying diagnosis. And it allows us to do things like get paid for brokering and accessing social determinants of health supports in pediatric primary care. So these two benefits, the family therapy benefit and the dyadic benefit, tied to the new 1915B waiver, is a reimagining of the medical model in youth and family mental health services. The care coordination and community networks that you, I know, are so invested in as you think through the community pathways and your prevention plans are going to have new funding sources. Perhaps the biggest is enhanced care management. And this is a new benefit paid at about $300 per member per month. So think like $4,000 a year or $3,600 a year per beneficiary. They have 6 populations of focus. Maybe this is a lesson to have fewer animations in your slides. So enhanced care management is one really important one. And the children and youth ECM populations of focus that go live in July 2023 are children and youth experiencing homelessness, children at risk of avoidable hospital entry. Number 3 is the big one. You can drive a truck through this one. Children and youth with serious mental health or substance abuse disorders. If you believe in the youth mental health crisis, if you accept the data that I gave you, that we are living in a time when twice as many of our children are trying to kill themselves, when suicide has leapfrogged cancer and car wrecks as a cause of death. I would argue at least 1 in 5, and the CDC agrees with me, of young people on Medi-Cal will meet criteria number 3. CCS kids, number 5 is you, children and youth involved in child welfare, and a very broad definition of involvement, and children with developmental disabilities and pregnant and perinatal populations. Community supports are these 14 cost-effective mechanisms to provide social determinants of health. Almost 2/3 or more than 2/3 of all managed care plans intend to offer all 14. These are the 14 benefits of community supports, largely focused on adults who are experiencing homelessness or at risk of homelessness and coming back from detention. One way to think of community supports is sort of the evolution of the whole person care demonstrations of the last 5 years. There are big chunks of money coming through the managed care plans that help build these networks, including the incentive payment program, IPP. These are dollars for plans to build networks, for family resource centers and other providers in child welfare networks. Know the name of your Medi-Cal managed care plan, give them a call, get in relationship with them, ask how they can support the development of your service provision. Cited grants, the TA marketplace and regional collaboratives. There's more. These are just some big ones, including the evidence-based practice grants. I know you're probably tracking. We're in round 2 of those grants. There's actually 6 grants coming, 6 rounds. And here's just a quick list of other big chunks of money: the practice transformation grants, the evidence-based practice grants, the community schools partnership work, and the behavioral health workforce and infrastructure grants available through HCI. One way to hold this slide is it's easy to do stuff with a $100 billion surplus. That's what we just come out of. We're now in a $32 billion deficit. So we're going to be tested. So sustainability considerations for your prevention plans are match what you're trying to do to the reform landscape. So the heart of integrity is specificity in this work. Regardless of your politics, the way to think about this is who's going to cut the check for the thing I want to do. So one big opportunity are these new non-specialty mental health services. That's the family therapy benefit and the dyadic benefit available through the managed care plans, the ones with the cool redefinition of medical necessity, with the kind of interesting and nexus of adverse child experiences and family support. Enhanced care management and community supports is also a new place you can get a check cut to do the kind of work you want to do for care coordination and social determinants of health work. Mine those expanded provider classes to build a healthcare system for people by people. Know that your county mental health plans are converting in July. This is a mouthful, so don't worry about the letters and the words here, but know that your county mental health departments are moving to a simpler claiming mechanism that should allow them and incentivize them to also partner, their providers to also partner with managed care plans. Basically, providers in the county mental health system have been constrained by cost-based contracts. That's going away. Under FFPSA, you obviously have your prevention plans and your evidence-based practices. Clearly, more work has to be done to clarify what the payer of last resort question. What we are proposing for consideration is just because Medi-Cal says it can cover something doesn't mean it does. Like EPFTT actually says that everything that is medically necessary must be delivered, whether it's listed in the state plan or not. So can Medi-Cal cover it? Sure. Does it? No. So the availability of a service or benefit is really important to determine whether it's viable or whether it's accessible or not. We believe that anything in the clearinghouse should be accessible based on the real availability of that service in a local jurisdiction. Your partnership with your county mental health department, which I know is strained in many counties, is really essential and important to generating federal matching funds. There is a new crisis service benefit that pays really, really well. So understanding it and accessing it is really important for your FERS systems. Medi-Cal administrative cleaning, something we've done with the FRCs in San Francisco. And I know I hate to beat this drum over and over, but please set aside any kind of historical or even internal or personal experience with your own managed care plan. If you don't understand the Medi-Cal managed care plan landscape, you're missing a big opportunity. Many of the reforms necessary or the dollars that will come to transform our systems are being run through the Medi-Cal managed care plans. And if we don't engage with them directly, we will miss an opportunity to improve child welfare. And Brian, did I bash through one of your slides? Sorry. Keep going. Okay. So how do we implement? Clearly, this opportunity to look at both the reform landscape of Medi-Cal and the reform landscape of child welfare together is as being focused on the same set of things, which distill to racism and poverty. So seeking consensus on the nexus of these two reform movements is really, really important. But we have to develop consistent, feasible case rate contract templates that land payers. So I'll drop in the chat a paper that we put out today about how to fund access to wraparound services by creating a contract that is co-funded by CDSS, by child welfare agencies, managed care plans, and mental health plans. So looking at how these three payers consolidate their procurement, purchasing, and contracting in simplified models is clearly the way forward. We have to develop tiered structures based on CANS assessments because that is the glue, that the tie that binds our two local systems. And we want to work with pilot counties to pilot this opportunity to do these three things together. So to reframe how we reach families upstream with Medicaid, we expand access points in pediatric primary care and schools. We use our screeners, the ACEs and ASQ screeners. We create fiscal incentives like community supports for social care under Medicaid. We developed closed loop referral services to non-medical services like Find Help, like Unite Us, like One Degree. We expand our eligible provider classes so that CHWs, counselors, CHWs, well, school counselors can also now bill, but CHWs, wellness coaches, peers, and doulas, building a culturally concordant workforce. And we eliminate diagnosis so we contain and constrain the historical complicitness of our healthcare system in pathologizing low-income communities.
So one question that we got as we were preparing this was, well, where does Families First and Community Pathways fit? And I'm going to try to answer that in two different ways. The first is from a funding perspective, from a strict dollar perspective. Families First is tiny right now for many, many, many reasons, including, you heard Alex mention the payer of last resort. So Families First funding for prevention dollars can only be used as the payer of last resort, and this includes Medicaid. Some states have defined that as being that if the Medicaid service is in the state plan, then they can't draw down Families First dollars for it. Other states have decided that if it's in the state plan of anywhere, they can't draw down federal dollars for it. And the fact remains that feds have not provided guidance. So Alex provided a very hopeful change to what that could mean, but the federal government hasn't provided guidance. And so states are unlikely to go out on a limb until that gets clarified in some way on the federal level. Number two, Families First can only be used for evidence-based programs. I mean, there's three categories, right? And those evidence-based programs are in a very specific clearinghouse. Sometimes when we talk about evidence-based programs, we're talking about stuff that's in clearinghouses that link to clearinghouses. And so there's actually a lot of services. For Families First, it's very specific to the Families First clearinghouse. And there's just not a lot of services in there. There have been more added in the last 18 months or so, but there's just not a ton there. And those evidence-based programs are just so far fairly limited. But really the proof's kind of in the pudding about where we are right now. So this is from Biden's budget. Only 6,500 children, so what this slide says, that's actually more than it really is. I realize that's an error. So it's only 6,200 children have been served using Families First funding nationally as of 2023. It's about $29 million in Families First funding that's been leveraged. And so from a funding perspective, it's tiny, but next slide. But from a convening perspective, an idea perspective, the idea that we want to go upstream and provide prevention, and that's what we need to do. Oh, can you go back? I think it's back. That's where we're trying to get to, is from a convening perspective and ideology perspective. And that's when we get, nope, forward, sorry. It's like driving a car through someone else. There we go. Oh, so community pathways. So, and that is what community pathways is. So when you're thinking about the link from community pathways, what is community pathway? Like, what is it with Families First? Well, it's any mechanism or avenue that families can use to access Title 40 funded prevention services outside the traditional child welfare service delivery. I'm going to expand it slightly. Any way you can access the prevention services that Families First is intended to deliver but does not fund can be considered community pathways. Community pathways does not come with additional funding. And so in a lot of ways, the things that we've been describing using Medicaid is one of the ways that we can realize the promise of Families First by adding a funding mechanism to it and do real upstream prevention work that also allows us not to have fidelity to the candidacy definition. So when we talk about at risk for foster care, if we're using Medicaid, we can push things way upstream to mean that for what it really means, which is young people that are impacted by poverty, which is exactly who Medicaid is designed to serve. Next slide.
So maybe I can end here. And I know we went quick, and I want to return to the chat. I think we have a little time for questions. Hung up again. The key takeaways is that Medi-Cal is changing. Like I can say, having worked in these systems for many, many years as a provider and an administrator, it wasn't but 2017 when state leadership told me that kids were doing just fine and we were making up our numbers. Now we have leadership who has fully embraced that our Medi-Cal program needs fundamental reform, and they are driving it. And it's fast, and systems change is hard, but big changes are here, and in particularly in behavioral health. There are funding streams and reforms to access criteria and fundamental shifts of who pays for what in relationships between actors like managed care plans and mental health plans. So big changes are here and ahead, like changes are coming. Please join us in embracing them. Understand the centricity of the managed care plans. Without understanding this fundamental shift, you will be missing so many opportunities. And it's difficult, and the managed care plans know very, very little about what you do. Like literally, I've interviewed the CEOs of most of the major Medi-Cal managed care plans, and they would say they know very little about child welfare. We need to teach them. Track the new and emerging Medi-Cal benefits, in particular, family therapy and dyadic benefit, ECM and community supports, those 4 in particular. And know that the access criteria has fundamentally shifted. It is true that all services must still be medically necessary, but the criteria for accessing them has fundamentally shifted. You now can qualify for them based on things that we know drive poor health outcomes. I'm not sure that anybody has billed more adjustment disorder not otherwise specified than me over the years, and we don't have to do that anymore. We don't have to game the system to treat away the things that are to treat and support families and children in addressing the things that are actually driving their poor health outcomes. Know the new provider classes and mine your local jurisdiction for non-federal dollars that are eligible for a match. You're going to need those CPEs to do work in community pathways and to expand access to community mental health services. So those things are everything from tobacco, from parking taxes, from assessment, from realignment dollars. Any non-federal public dollar that isn't already being used to match a federal dollar is a CPE. So think about like a naked public dollar. No one should be spending a non-federal dollar naked. You should be getting it matched through child welfare or through healthcare. You can read our policy briefs here. You can track us on social media. Thank you so much. Let's jump into the chat and try to get some questions done.
I guess I don't want to wade into it too much, but just as we're waiting, I see in the chat, there's a lot of back and forth about medical necessity versus access criteria, and the fact that the state did not try to redefine what the federal statute is, which is, of course, entirely true, because that, of course, would be impossible to do. But it's a very good point. Medical necessity exists in federal statute, which is why that Medicaid is the last great entitlement. But the access criteria, and the state has done something incredibly progressive. Instead, if you meet the access criteria, which includes child in foster care, you're automatically eligible for a specialty mental health service. Then you have to have some level of assessment to figure out what that specialty mental health service is. So you get something, but what do you get? Well, what do you get is medically necessary, and what would that be based upon the assessment tool?
Yeah, and also just I'm looking at the chat now, and thank you, Dr. Gauthier. I'm sorry if I'm saying your name incorrectly. So it is actually true that in the non-specialty mental health system, you don't have to have a diagnosis, and that Z codes are now eligible for reimbursement. So I do need to be, I think we can, I'm just looking at some of the stuff here in the chat. I'll drop some links to I'll actually drop a link to the non-specialty mental health provider manual. Page 2 is medical necessity. Page 4 is eligibility criteria. Page 13 is the dyadic benefit, and page 26 is the family therapy benefit. And you do not have to have a qualifying DSM-5 diagnosis to qualify for either of those 2 new benefits. And I do, but I also want to acknowledge and appreciate the no wrong door policy. It is true that you don't have to have Even in the specialty system, you don't have to have a diagnosis to start care. And yeah, I'll stop there. We can get lost in this kind of circular conversation of medical necessity and criteria. But what I would argue as well is that the new criteria 1 of the 1915B waiver also has a trauma door. The trauma door means screening at high risk in a DHCS approved trauma screener. Right now, that is the PEARLS, but I'm hoping there will be more.
Could one of you give a tangible example of how a clinician would use one of these social determinants of health Z codes like Z6281, personal history of child abuse? I get the sort of global context, but I don't understand what happens at the individual level.
Yeah, so I'm not familiar with that Z code being eligible for reimbursement in the family therapy benefit, the dyadic benefit. But again, I'll drop the provider manual into the chat and you can see which Z codes are eligible. I'm not sure that one qualifies under either the family therapy benefit or the dyadic benefit.
Yeah, Z55 to Z65 are all the social determinants of health codes. So if any one of them, let's say if any one of them happened to be, just in general, happen to be eligible, how would that work?
Right. So let me take you back here. So the non-specialty, remember the specialty versus non-specialty. These are the new names. Specialty is county, non-specialty is managed care. And in order to be eligible for reimbursement in either system, you have to be paneled and credentialed with it. Paneled and credentialed means you have to get an MPI and be registered at the state as a Medi-Cal provider, and you have to sign up locally with your Medi-Cal managed care plan. Many managed care plans use what's called a BHO or an intermediary to administer their non-specialty mental health. You know them as Beacon, Magellan, MHN for HealthNet. Some of the big plans are increasingly, the public plans are bringing that benefit administration in-house. So like Alameda Alliance is bringing it in-house. Their Beacon used to do it. LA Care uses Beacon. Partnership uses Beacon. These are subcontractors who administer the benefit. They build the network and then reimburse claims. So let's, in this case, to answer your question, Locke, directly, for the benefits that I'm talking about right now, the family therapy benefit and the dyadic benefit, you have to be a master's level clinician to qualify to bill them. Now you can be pre-licensed. You can be an MFTI or an ASW, and you have to sign up with the Medi-Cal managed care plan in your jurisdiction. And once you're paneled and credentialed, you drop a claim. There is no pre-authorization. They're being reimbursed at fee-for-service rates of about 70 to 90 bucks per service. But beginning in 2024, they are going to go up to Medicare rates, not Medicaid rates. So you'll see a rate bump to 110 to 130 per visit. So you basically drop a HCFA lock for your, a service encounter form in each county, and each provider has a different form you fill out. But it does not at all resemble like specialty mental health contracting. It's way simpler. There's no contract necessary. You are paneled and credentialed. And there's no contract cap like there is in specialty mental health. Look, if you want to send me an email, I'll put my email in the chat. We can talk separately, and I'm happy to connect you with the managed care plan in your jurisdiction.
Perfect. Thank you.
We have 5 minutes. Any other questions? So we say try to stump Alex portion of the presentation.
I dropped a quick article about the new family therapy benefit, an art that describes the medical necessity reimagining. And I'll drop the provider manual in as well. The provider manual here, the last link I put in, again, page 2 is medical necessity. Page 4 is eligible providers. Page 13 is dyadic. Page 26 is family therapy. And then at the end of the document are the eligible codes.
Alex, here's a great question from Erica. So small rural counties, agencies set up for billing for these services are limited. What advice do you have to increase the access capacity in those counties for actually billing for these services?
Yeah. So the first thing to know is type into Google DHCS Medi-Cal Managed Care Directory. And up will come a page where the name of your county will be listed, and you click on it, and it will tell you the Medi-Cal managed care plans that serve your county. If you're a small rural county in Northern California, you are going to be covered by Partnership. And Partnership is really cool, by the way. They're one of my favorite Medi-Cal managed care plans. Mark Bontrager is the guy who runs their mental health services, and he's super awesome. The vast majority of Medi-Cal beneficiaries in the small rural counties are paneled, meaning assigned to a primary care provider in an FQHC. So my recommendation to you is to identify the community health centers, the FQHCs in your jurisdiction, and look to partner with them because they get special rates from the plans and the state and the feds. So the 3 steps I would encourage you to do is 1, make sure you know the name of the Medi-Cal managed care plan that covers your county. 2, know the name of the community health center that serves low-income beneficiaries in your region. 3, call Mark Bontrager if you're in Northern California. Also, that's going to be super, super key for ECM as well. Those same providers that can do these new non-specialty mental health benefits, static and family therapy, are going to be the same providers who are likely to be ECM providers, enhanced care management providers. And then the last recommendation I would make is for kids in care, and I'm sorry to do this, keep doing this and over, but for kids in care, I think if you asked 100 of us who worked around foster care, what do kids in care need? 94 of us would say high fidelity RAP, intensive community-based mental health services, a team with a therapist, but not only a therapist, but also people who look like the young people we're serving with relevant lived experience, who basically show up for them every day, all day long, and never give up. That's RAP. And RAP, unfortunately, only serves approximately 15 to 20% of kids in out-of-home placement. And we believe it should serve everybody. So the other place I would go is to the community-based organizations that have contracts with your county mental health department and explore with them opportunities to expand wraparound through new partnerships with Medi-Cal managed care, your complex care funding, and FFPSA.
And Alex, one more question that I know we've gotten before, and it's related to Erica's question. Can you talk a little bit about the new service classes and the real stressor around workforce capacity right now, workforce shortage?
So could you say the first part again, Brian?
So how the new provider classes could help solve the workforce shortage issue?
Yeah, so I think this is the most exciting opportunity in the nexus of our 2 systems, is the declinicizing and the democratization of the mental health workforce. And I just feel like it's the most important opportunity out there. So I know as we head out back to our breakout rooms, look at the community-based organizations and the health system providers and ask them, are you hiring CHWs? What are we doing with the doula benefit? What are your plans to put wellness coaches in schools? And do you have plans to expand your SB 803 certified peer counselors? Those are the 4 essential ones. Gosh, is it to contract with school district support building? Jory, send me an email. I dropped it in the chat. We're 100% philanthropically funded, so we don't have to be beholden to anybody, but we'd love to help you. So the answer is yes, we help everybody. We're free, but we only have a 1.5 years left. So we're sprinting to the finish line. So we'd love to talk to you.
Thank you, Alex and Brian. Thank you to everybody.
Close to 600 when folks went into their breakouts. So see if we get the majority back.